So today we're just going to finish up the pediatric in emergency radiology topics. We have just three more topics left, which are pyomyositis, child with a limp, and non-accidental injuries. So we'll start with pyomyositis, which is a primary infection of the skeletal muscles. It is more common in the tropical countries, but it is being reported now worldwide. It can affect immunocompromised and immunocompetent individuals too. The most common organism is Staph aureus, and pyomyositis can also is also associated with abscess formation. You can use ultrasound, which is simple and readily available to pick up pyomyositis, but you can actually miss it in the very early lesions. MR is a preferred imaging technique. This is because it can image a larger area of the body, and it can also detect subclinical involvement, and also can detect adjacent bone and joint involvement, and exclude other soft tissue disorders as well. So we have primary and secondary pyomyositis. We'll go through primary pyomyositis, which occurs via hematogenous spread from prior transient bacteremia or concurrent bacteremia. The bacteremia may be idiopathic or secondary to a remote site of infection. Traditionally, primary pyomyositis was referred to as tropical myositis or tro- tropical pyomyositis. This was because it was more common in the tropical regions in the world. However, it has now become the disease has been picked in different other climate, and now there are following terms that can be used interchangeably due to this. So you have the term primary pyomyositis or tropical pyomyositis, tropical myositis. You have infectious pyomyositis, pyogenic myositis, suppurative myositis, myositis purulenta tropica, myositis tropicans, epidemic abscess, pyomyositis, and bacterial pyomyositis. These are all terms that can be used just to describe primary pyomyositis. Secondary pyomyositis is caused by extension of primary infection from contiguous bone, joints, skin, and soft tissue. It can also arise from the GI or GUT tract and other organs, or directly from an open wound. The signs and symptoms you can have for the local signs and symptoms, you have muscle tenderness and edema, which on palpation will have a woody texture. Systemic, you can have regional adenopathy and fever. And if the pyomyositis is involving the psoas muscle, the patient will keep the hip flexed. And if you extend, there will be a lot of pain because of the irritation. So this sign is also similar for appendicitis, and it is good now to rule out to rule in or rule out one or the other. Complications are septic emboli, endocarditis, septic arthritis, and in the severe form, septic shock. The stages, you have an invasive stage, which is subacute, occurring over 1 to 3 weeks, and here you have local painful swelling, which is with a wooden consistency, with or without erythema. And then you have a suppurative stage. Here you have fever that is present. This occurs between the second and third week, and the area is extremely painful and tender. And on imaging, you may see an abscess. That is in the suppurative stage. So sonographic features. Edematous muscles show reduced echogenicity, and muscles with fat infiltration show high echogenicity. Acute pyomyositis with low echogenicity. Okay, in acute pyomyositis, you have low echogenic muscles that are of normal size, and in chronic, they show higher echogenicity and they are smaller in size. The investing fascia may also show some abnormalities, which may be a loss of the sharply demarcated margins. There could be increased thickness of the fascia, and also or visibly disrupted, or the fascia will show an outward convexity that is due to the underlying expansion of the muscle. Color or power Doppler would show tissue hyperemia in the absence of necrosis and the presence of an abscess as well. So an abscess will present as a discrete collection. It will be heterogeneous and less echodense compared to the adjacent tissue, and it will move independently from the surrounding structures during graded compression, which will term it as sonographic fluctuance, that is of the abscess. So we go through a few cases. Here we have an 18-year-old with pyomyositis. The location of the pyomyositis unfortunately was not stated, but on the first sonogram, you're seeing a hypoechoic collection that is seen in this area, and after evacuation, you can see there's still a bit more of it left, but you can now see the normal muscle which is there. And this shows also another role of ultrasound, which you can use it for ultrasound guided aspiration of an abscess or fluid collection as well. So here you have pyomyositis of the quadratus of femoris in a 15-year-old girl who had end-stage renal disease. And here you have a soft tissue ultrasound showing enlargement and in homogeneous hyperechogenicity of the right muscle. This is of the normal side, and you can see that there's a difference in the echogenicity, and you see that muscle is not a bit, it is echogenic compared to the normal side. And this was in the quadratus femoris muscle. This is on an axial T2 weighted, but there was no bone and involvement or joint involvement in this case. All right. So we'll proceed to the next case. Here we have a 5-year-old boy with pyomyositis of the right obturator internus muscle. The child had an ultrasound and an X-ray done, which were negative. They didn't show any sign of infection or any problem. So they progressed to MRI, most likely because of the continuing complaints of the child, and it showed that there was these are tissue fat, these are fat suppressed images. So it showed muscle edema, that is of the obturator internus muscle, and a collection which is hyper intense with a thin hypoechoic ring that is visible. And then on a fat suppressed T1, you can see the hypoechoic lesion with a rim of enhancement, and also the muscle edema which appears echogenic. So this was myositis now, which now formed an abscess.
But this is MRI. So
Yes,
was a muscle looking bright on this T1 weighted image?
the T1, this one was T2 with fat suppressed. This
Mhm.
one was T1 with contrast.
Because of the contrast. So there was contrast
Yes,
enhancement as well
yes,
in the inflammation in the surrounding muscles. And
muscle.
then you can see that fluid collection, right, with a enhancing rim. Yeah, I just wanted
Yeah.
you to pick that up. So was anything in the bone?
No, the X. Oh no! Oh no! No! No!
Just look at
Oh
the.
yes, yes. There is of the pubic bone on the lateral
So
side.
this hyperintensity you're seeing on the T1, it's enhancement. The hyperintensity
Mm,
you're seeing on the T2 is edema, again of the
yes.
bone marrow, of the pubic symphysis,
Mm,
right? Yeah, okay.
yes.
Mm.
Yeah.
Or the pubic bone, the bone itself, actually, the pubic body. Yeah,
The pubic.
that's
Yeah.
fine. Mm.
Okay. All right. Thank you. So we'll go So a limp is defined as an uneven, jerky, or laborious gait, usually caused by pain and weakness or deformity. Limping in a child can arise from the hip or lower limb or lower limb pathology, or from a remote site, which is from the spine, abdomen, or pelvis. There's a wide list of differentials that range from benign to life threatening. So once a gait's abnormality has been identified, it requires a thorough history and a physical examination so that you can narrow down your list of differentials. So the patient often has tenderness or loss of range of motion at the site of the pathology. So these are the various differential diagnoses when you encounter a child with a limp. You can have infectious causes, which are arthritis, osteomyelitis, discitis, and epidural abscess, psoas abscess, appendicitis, or retroperitoneal abscess. In an inflammatory, you have transient synovitis, juvenile idiopathic arthritis, and this was pilonodal. I've forgotten the full name for this, but I'll check. And then trauma, you have a fracture. So a toddler's fracture or a spiral fracture, a stress fracture, and also non-accidental injuries. Developmental, you have DDH and SUFE. You can also have tarsal coalition. In osteonecrosis, the differentials can be either sickle cell anemia, Lecave path disease, or osteochondritis dissecans. And then you have osteochondrosis. Hello? Did someone have a comment? Right. On tumors, you can have either malignant or benign tumors.
It's Dr. Sada giving you the
Pilonodal
full name
vein.
of the PVNS, huh?
Yes, or
Complemented vellonodular synovitis.
yeah. Thank you. So for this one, for most of the differentials, we've already gone through them either in Sada's presentation and mine, and some also in the abdominal. So I was thinking maybe we can go through the appropriateness of imaging, and then we'll also look at some cases after that. So this was from the ACR appropriateness criteria for an acute limping child up to 5, and this were their recommendations. They had 5 variants of children from variant 1 from a non-localized symptoms with no infection to localized with infection, and what would be the appropriate imaging to do first in such a case. So we have a key here. The key is is color coded, but it's just for me to read it out. It doesn't mean anything. So an image is usually appropriate. This is the imaging procedure or treatment is indicated for that scenario. And then may be appropriate is that the imaging procedure or treatment may be indicated in the specified clinical scenario as an alternative to imaging procedure or treatments with a more favorable risk benefit ratio, or when it is uh, equivocal. May be appropriate is when the ratings are too dispersed from the panel median. So the different label provides transparency regarding the panel's uh, recommendation. So it may be appropriate, but they might disagree, and then you have usually not appropriate.
What,
So
what does that green mean, really?
now for this one is what I was trying. It's like there's no consensus.
Yes, there was a panel of
Yeah.
experts, and
Yes.
normally all of them should come to a consensus, right? And say
Yeah.
this imaging modality is appropriate or not. But when it is green, there were two very divergent views, huh?
Yes.
And that's why it is green. There was disagreement. So there
Yes.
was one who said it's appropriate, the rest were more or less disagreeing, and that's why it is now green. But now, like the black one, they just all of them would agree. The
Yes.
median, the of average, would agree that it is not appropriate. Yeah.
Yeah.
Okay.
So for the first variant of a child, this was a child up to 5 with an acute limp with none localized symptoms, and there was no concern for infection. And for this one, they agreed that the primary imaging is radiograph of the tibia and fibula, followed by, and the others may be appropriate, which are radiograph of the femur, the foot,
Okay, the procedure here will depend on where after
where they
clinical
did them.
examination,
Yes,
it's
yes,
leg, do you think it's thigh, do you think it's foot, do you think
yes,
it's spine, do you think it's pelvis? And then you want to do an x-ray of that region.
yes,
So if you think it is tibia fibula, then it's usually appropriate. But
appropriate.
if you think it is from the pelvis, then the radiography of the pelvis will not be appropriate. And then it even shows you the amount of radiation. Yeah, you
Yes,
have two radiations to that, right? But
yes,
yeah, so you need to think of something else. Do you need maybe to do another imaging modality? So again, like ultrasound of the lower limb, it's not appropriate. Ultrasound of the hip at age 5, definitely not appropriate. And then the CT scan, again, all of them are really not appropriate. And again, you can see the radiation dose
yes,
is
yes.
it's quite high. Yeah.
So for variant 2, there was an acute limp and pain with localized symptoms and no concern for infection. So you do the radiograph of the area of interest, the low extremity of the area of interest, which was appropriate. The rest, they put it as usually not appropriate. So there were those, they
Yeah, all
disagreed.
the rest were not appropriate.
Yes. So for the variant 3, this was a child up to age of 5 with an acute limp with non-localized symptoms, but there was a concern for infection. For this one, they agreed that the MRI of the lower extremity with or without IV contrast is appropriate, and MRI of the lower extremity without contrast as well was appropriate. For the ultrasound, MRI whole body and with or without contrast, and without contrast, they put it as maybe appropriate. The rest, they say, is not appropriate for examination for this child. And then for, yes,
Why do you think they qualified and said usually not appropriate?
for the ultrasound,
For all these not appropriate ones, they all have usually not appropriate. There's a qualification there. Where can they not be dogmatic and just say not
not
appropriate?
appropriate.
I think they're just giving a window because you see, medicine, you really never say never. And
Never.
somebody can come with a certain kind of a presentation whereby actually that is the imaging that will be most appropriate. And
Mm,
here you've said not appropriate and you're sending this forward as guidelines and you can have litigation. So it's
ah,
actually just to protect yourself from litigation, actually.
ah,
Yeah. And that's why they are qualifying this
using.
appropriateness criteria. Yes.
Ah, all right. So for variant 4 is a child up to 5 with an acute limp with localized symptoms to the hip, and there was a concern for infection here. The ultrasound of the hip, MRI pelvis with or without IV contrast, and MRI pelvis with or without IV contrast was usually appropriate. So this is because it's a localized area and you will be able to see. But as Dr. Mongo said, up to 5, you'd rather go with an MRI for that area. And then the rest may be appropriate.
Now, look at the clinical history.
Yes,
Here
for
we
the
have concern for infection, and this is the initial
infection.
imaging. You can do hip, even for an older person, even for an adult. If you think it's a septic arthritis, you can do actually an ultrasound of the hip, of the pelvic, of that, because you want to look for effusion within the hip joint. But in the previous one, the variant there was no
Oh, no
concern for
concern.
infection. Eh?
Oh,
You cannot see that.
the
Yes, no concern for
yes.
infection. So if there's
Oh,
no concern for infection, it's a child of an old child, you wouldn't do a hip
you
ultrasound.
wouldn't do a hip
Yes,
ultrasound.
yes,
Okay,
yeah.
I
So again, it
understand.
always depends on your
And
clinical
then,
scenario.
yes. And then you have a child up to 5 with symptoms localized to the lower extremities, which are not pelvis or hip. So here, the usually appropriate was MRI of the lower extremity of the area of interest with or without contrast, or just the MRI without contrast.
And here again, Doc, there was a concern for infection. And
Yes.
then the choice of imaging will now depend on that.
Mm.
But normally they tend to start with the lower grade, whatever, and then as they progress upwards, right? Yeah.
Oh, it's just the small things that they put now in the discussion for infection and non-localized symptoms. The concern was a spiral tibial fractures, which were most common in children under 4, and that's why they recommended radiograph. But what I was saying is that on initial imaging, you might miss this image. So that this fracture, which is why they said it is important to have follow-up imaging. And with follow-up, around 10% of missed, they found these fractures in about 10% of follow-up radiographs that were done, which were initially missed in the first imaging. And then this was for up to 5, yeah, or child up to 5 with
To say, in the previous one, the spiral, this is a child who is walking, and sometimes they can have this as part of a stress fracture.
oh,
And that's why in the initial imaging, you might actually miss, but after maybe a week or so, when colors forms, then you're going to pick it up.
okay,
As opposed to if it was a child who was not walking,
mm,
you know?
yes.
Yeah, because then you'll have to start thinking a spiral fracture. Is this an accidental injury? Okay.
So this was variant 2 was a child up to 5 and with localized imaging, localized symptoms with no concern of infection. The body regions here that they covered were hip, femur, knee, tibia, fibula, ankle, and foot, which may be due to trauma. So you do targeted radiographs of those areas too evaluate the fracture. The most common one that they found was a toddler's fracture, which is an oblique distal tibial fracture that often go and recognized. And there was a study that they did that they took 39 children with a presumptive diagnosis of toddler's fracture, and on follow-up imaging, that was 16% of those ones who were presumed to have this fracture actually had evidence of toddler's fracture. So again, the importance of follow-up imaging for this one. For variant 5, this was a child with a limp with non-localized symptoms and a concern for infection. The recommendation was an MRI. That's because of there's a large field of view, and you do a coronal T1 weighted and fluid sensitive sequences covering the pelvis and the pelvis, hips, and to the ankles. And if you get where the problem is, now you repeat now with the, or you can do not repeat, do additional sequences with a smaller field of view. Contrast was given just to have a higher specificity and sensitivity for abscess diagnosis. Child with an acute limp with symptoms localized to the hip and a concern for infection. This one, the pain was localized over the hip, and the diagnosis they said should be septic arthritis until proven otherwise, which is the most common cause of acute severe monoarticular pain in children. In children, the sign with signs of infection and abscess of hip and absence of hip effusion, diagnosis of pelvic osteomyelitis or pyomyositis should be considered. Ultrasound of the hip is quick, and it's quick and gives accurate diagnosis of joint effusion, and can also be used for guided aspiration. A false negative was uncommon, but when it is in the acute stages, that's within 24 hours, then you can miss some of the subtle changes. But most of the time, almost all the time, it was accurate for diagnosis. And child up to age 5 in an acute limp with symptoms localized to the lower extremity, that was not pelvis or hips. In this scenario, is that you have either The body regions are the femur, knee, tibia, fibula, ankle, and foot. So this one, they recommended MRI. It's because of its sensitivity in musculoskeletal in injury and in inflammation, and as well with its added advantage of picking out osteomyelitis and pyomyositis. So we'll go through one or two cases of a child with an acute limp, even though we've already gone through several. Here I'll just cover a few. So we'll go through slipped upper femoral epiphysis or slipped capital femoral epiphysis, which is more common in boys and it presents mostly at 10 to 17 from the what my reference, and girls at 18 to 15. It's more common in African Caribbean patients. The risk factor is obesity, hypothyroidism, hypopituitarism, hyperparathyroidism, renal osteodystrophy, radiation, stroke, chemotherapy. Clinical presentation: if it's acute, you have severe hip pain with inability to bear weight, usually after minor trauma with prodromal symptoms such as vague groin pain or thigh pain for up to 3 weeks before the acute presentation. Imaging findings for the frontal radiograph, you may see widening of the physial plate, a line drawn tangential to the lateral margin of the femoral neck does not intersect a portion of the epiphyseal ossification center. I'll show you the line, and usually the line should intersect part of the epiphyseal ossification center. Frog leg or lateral view better demonstrates the offsetting of the epiphyseal margins relative to the underlying metaphysis. You can have head and neck demineralization, which may be seen for shortening of the femoral head with increased density inferior to the growth plates due to superimposed base of the epiphysis or a reactive sclerosis, which may cause now the shortening of the femoral head. And if it's chronic, you can see buttressing of the femoral neck both posteriorly and medially, or sclerosis of the subphyseal metaphysis. So for CT, better delineates the epiphyseal offsetting that is not usually required because most of the time the plain radiograph you can make the diagnosis with it. So here you'd have posterior and medial displacement of the epiphysis relative to the proximal metaphysis. MRI not usually performed acutely, but it will help if you suspect a vascular necrosis of the femoral head. The physioplate widening is seen on T1, and on T2 you can see synovitis and bone marrow edema, which will show as increased. It will be hyperintense. A case here, we have a 12-year-old obese boy who presents with bilateral hip pain, which was worse. Which was worse on the left. So here we have a plain radiograph. This is an AP radiograph, and if you compare the left and the right, the bone mineralization seems the same. And then if you notice, you can notice the left epiphyseal plate is more prominent compared to the right. That's of the femoral
It's more
head.
prominent or widened? The word is
Yes,
widened, huh?
it is widened.
Mm-hmm.
It is more widened compared to the right.
Yes. Anything else? No, wait. What else did you do?
Huh?
A clean line?
Sorry?
Clean line.
Or clean line, the one that passes through the femoral
Mm-hmm.
neck.
Mm-hmm.
Yeah, if
Mm-hmm.
it passes through the femoral leg, it
It's
should.
tangential to the femoral neck
Yes,
and should pass through part of the
of the
epiphysis.
epiphysis.
So
Yeah,
if it doesn't, then you know there's a slip.
yes,
But I can see in the frog's leg, it's there.
yes. In the frogs, like this is a clean line, which is now tangential to, and you can see that the epiphysis, the line does not intersect any part of the femoral epiphysis.
But you see, in this frog's leg, it doesn't intersect even on
Ah,
the right side. Yeah,
yeah, it doesn't.
that's why you do it on the AP.
Oh, okay.
Yeah, so you look at the AP.
Mm.
Go
Sorry.
back. Yeah, so if you do it on the AP, you can see on the right it would
Mhm.
intersect,
Yes,
but on the left it doesn't.
it
So you know
doesn't.
there's a slip on the left, but the risk would be high of even the right also slipping. So when they fix,
Mhm.
they tend to fix both joints. Huh?
Yeah. Oh, okay.
Mm.
Yeah. All right. So, and then on CT, so this was through the right. We have the right hip and the left hip, and now here we can see the widening of the epiphysis on the right, but it's more obvious on the left with the displacement of the femoral head. That is, in this one would be posterior. Yeah, so there's displacement of the femoral head as well. So CT scan, you can make the diagnosis with the radiograph, but you can also do a CT scan.
So is the right slipped?
For the right, now on this, not as obvious as the left, but I
You
think
can
here
do a
so,
plain line on this view, but
mm,
definitely what has slipped is on the left side,
left.
isn't it?
Yes.
Yeah.
So an ellipsoas collection for here, let's say the presentation if the abscess or the infection is on the source, the patient will be flexed and there will be pain on extension. So this is an ultrasound of the hip and inguinal region, showing a hypoechoic fluid collection, which is there, and this is a source muscle that is on top of the hypoechoic lesion that we see on ultrasound. A follow-up an MRI was done as well. And here we have T2 fat suppressed images, axial fat suppressed images, and here we have T1 fat suppressed images. And in the T2, you can see a circumscribed hypointense lesion that is visible on the T2 fat suppressed, and
Which
then
is
the
the
T1
different one?
postgraduate. Yeah.
It's not the bright one, because that's T2.
Wait. Oh, sorry. Yeah, here. Sorry.
Within the muscle, because I think what you are
Yes.
printing would have been a bowel loop. Huh?
Power loop. Yeah,
Yeah.
sorry.
And then
Yeah.
you can see it on T1. Again, you can see
T1 as well.
it's hyper
Yeah.
intense, yeah, the fluid density.
Yeah,
Yeah.
sorry. So there it is. And yeah. So that's the collection on the on source collection. So a spiral hairline fracture here is a radiograph of a 3-year-old with acute limping, and on the AP, you can't demonstrate any pathology. It appears normal, but on the lateral, there was a hairline fracture. Sorry, a spiral hairline fracture. I don't know if I zoom in, I think the image quality might be degraded, but there's a lucency that they're pointing to right anterior to the arrow. I think maybe once if I zoom in, it won't be very visible. Yeah, but I
No,
think
when you zoom in, you're just seeing the overlap of the tibia and
yeah,
femur.
the
Yeah.
tibia. Yeah, yeah.
But
So
if one suspects there's a spiral fracture, one can always do a follow-up. Huh?
yes,
Yeah.
yeah.
Would ultrasound help?
For a spinal fracture,
Hmm. Can
uh,
you see fractures on ultrasound?
fracture. Um, well, maybe if you follow the continuity of
Yeah,
a
you'd actually look at the continuity. You might actually pick them up. There's
yeah,
been one or two studies whereby they have shown that you can pick up fractures, especially rib fractures.
mm,
If you just go to where the patient is feeling the pain, and you pick up the fracture.
mm,
Of course, an MR would pick up the fracture quite well, because again,
yeah,
you'd see the fat suppressed T2. You'd see now the marrow increase in marrow intensity. Then you know that is where the issue is. Huh?
yes.
Yeah,
All right.
and you may see fluid tracking through
Oh,
the cortex. Yes.
okay. All right. Thank you. So from there we go to non-accidental injuries, which are a sign of physical abuse of a child. So here the radiologist may be the first staff member to suspect these injuries when confronted with a particular injury pattern. It is important to have a skeletal survey done on the child, although this can be tasking emotionally and also technically. So you will need someone, a radiographer or you yourself, who's very well trained and can deal with that, with the whole rigorous process. Um, some centers usually have a minimum of two radiographers who are trained and should be present during this examinations. And the recommendation is that you use anatomical markers and not digital markers. So you need to have that present as well. The images need to be free from motion artifact and use appropriate immobilization techniques that should be used. And if this is done, you have to write who in the room was present during that time. And a single radiograph of the entire patient, a babygram, is not recommended, and it is not appropriate for suspected non non-accidental injuries. So the role of a radiologist when confronted with a patient with physical abuse is to be aware of the possibility of child abuse, to recognize the subtle signs on radiograph, to recognize the discrepancies between the history and nature of the injury, to estimate the age of the fractures, to know the imaging protocol in case of suspected child abuse, and to be aware of the local child abuse protocols, and to have proper communication with the referring physician or pediatrician, and to make an adequate report of your findings as well. So for this one, this recommendations that are done by the Royal College of Radiologists, the radiological investigation of suspected physical abuse. This was a revised first edition, which was done in the year of 2018. So I'll just go through some of what is required from us as radiologists and what we should also expect from the physicians. So, what imaging is required? You need a skeletal survey for the children and under 2 years old, and a skeletal survey and CT head in children under 1 year old. Who are older, for children who are older than one and have external evidence of head trauma and or abnormal neurological symptoms should be included. Skeletal survey may occasionally be indicated in older children, depending on the case-by-case basis. These are patients who have learning difficulty with communication or any neuro disability where you suspect that there is uh, child abuse. And then, if you have a primary child, your primary patient who is under care uh, of the parent who also has other children who are under two, the same children should also go have the same imaging done, because they might also have the same be under the same kind of care as the one who's been brought to hospital. There are about 40 recommendations, but I just took a few snippets from here and there. So, requesting imaging, you must have complete clinical information, which must be provided with a request, which will be justified by the radiologist. The referring clinician should provide clear explanation to the person with the parental responsibility of the reasons of the imaging. And then a written consent from the person with the parental responsibility should be obtained. And if this can be overridden only if it is an emergency, and also can be overridden in court as well. But usually in our system, we don't have the whole process of court. So consent of those in individuals with parental responsibility should be verbally reaffirmed by the examining radiographer, and if consent is withdrawn, the examination should be stopped and the case referred back to the consulting pediatrician. For the skeletal survey, it should be acquired and reported within 24 hours and not more than 72 hours from the request being made. Two radiographers with a documented education and training of imaging of suspected physical abuse and forensic radiography techniques should perform the examination. They should have level 3 knowledge. That one I'll check what level 3 knowledge is and then I'll post. In the event that the trained radiographers and radiologists are not available, there must be you must organize for the patient to go to a suitable hospital where you have those people who are skilled no later than 72 hours after the request. And then once if those people are there and you are part of the team, you must have correct identification of the child by both radiographers and involved in by you have to have correct identification and you have to document the time of examination. The people who are allowed to accompany the patient are a registered nurse or an appropriately educated health or care practitioner who is statutory registered, to carry out the examination. These are people who are able to act autonomously. They have a scope of practice, which includes an understanding of the legislation. People who are not allowed to do this particular examination or to accompany are oh no, the people allowed are registered child nurse and as a social worker. Those who are not allowed are a student nurse, radiographer, healthcare assistant, assistant practitioner, or associate professional. So those are the people who are not allowed to accompany. And then for the reporting, you need two radiologists with at least 6 months of specialist pediatric radiology training who will give their consensus report within 24 hours. Clinical reports should adhere to the standards for interpretation and reporting of images, which is from the clinical data, presenting complaints, and now your findings and conclusion. And then findings from the image should be actively communicated to the requesting clinician, and there should be what do I say? There should be a way that you can discuss the patients for in like um, MDTs.
Yes. So a follow-up image should be done between 11 and 14 days and not later than 28 days for the initial um, skeletal survey. So if you're doing an enhanced cranial CT scans, they should be done immediately. Those are below from the skull base to the vertex. The thickness that is required is a thickness of 0.8 millimeters with 3D surface reconstruction as well. Multiplanar reconstruction should be in the true coronal and sagittal planes. MRI head is performed at day 2 to 4 for all children when CT shows a positive finding such as hemorrhage or parenchymal brain injury. Yeah, so MRI should also be performed at day 2 to 5 for children who there are ongoing abnormal neurological symptoms, which are irrespective of an apparently normal initial CT scan. Any child that has had an MRI of the head should also have MRI of the whole spine at the same time. And children who are older than 1, some injuries have a higher association with abuse and head trauma, such as rib fracture, spinal fracture, and retinal hemorrhage. In such cases that present acutely, you will need to do a CT image, which should be considered. And then CT and MR scans should be reported by pediatric neurologic by a pediatric radiologist, and again within 24 hours. Craniospinal should be done at 1.5, that's MRIs, 1.5 Tesla or 3 Tesla, and the child should be accompanied by a whole team, that is the nursing, the radiographic, for need for intubation. Follow-up MRI also may be indicated. Where there's a historic abuse, and the child may present with unexplained neurological abnormalities, neurological developmental concerns due to, in the context of suspected physical abuse or an unexplained increasing head circumference. The first line imaging for this child is MRI of the head. Yeah. And then you can use just the protocols that are there, and any CT or MRI
should be acquired and reported within 24 hours and not more than 72 hours.
This one, for a deceased child, there was a rule of postmortem imaging for those children who have sudden unexpected death in infancy. And here you do of the whole body. You can do for MRI also if you have some soft tissue injury also, you'd also do an MRI to be able to pick up any injuries that might have been missed or not explained. So those are some of the recommendations that they had for that. So, hello, we're together.
Yes, we are. Yeah.
Yeah.
So,
Continue.
For the skeletal survey, you do head, chest, spine, and pelvis. You do AP and lateral of the skull, AP chest, AP abdomen and pelvis, and lateral views of the pelvis. For the upper limbs, you do upper limb of the whole arm or just of the forearm and the arm for older children, and coned views of the lateral elbow and wrist, and PA of the hand and wrists. In larger children, as I've said, you do the humerus and the forearm with the same images as with this as a coned lateral elbow and wrist. For the lower limbs, you do whole AP of the lower limbs, that's hip to ankle, and then coned lateral of the knee and ankle, and coned AP and DP of the foot. For larger children, now you'd go by the specific bones. AP of the femur, tibia, fibula, knee, ankle, and coned lateral of the knee and ankle, and DP of the foot. Follow-up imaging around at 11 to 14 days and not later than 28, and you do for those areas where you found that there was an abnormality or there's something that you picked. And then upper limbs, you do for the whole arm. Yeah, this is just basically the same thing that I just mentioned. That's for follow-up. And then for the brain, for MRI, you do sagittal and axial T1, axial T2, and axial-coronal flare, axial T2 or SWI and or PWI. For the spine, sagittal T1, T2 with a star, and axial T1 and T2 image as well. So we'll go through some of the injuries that would make you have a higher suspicion or moderate or low suspicion for non-accidental injuries. For those ones that occur infrequently but have a high specificity for abuse are metaphyseal, rib, and scapular fractures, especially at the acromial region, and then fractures of the outer third of the clavicle,
sternal fractures, and spinous process fractures. Those that you have moderate specificity for abuse are multiple fractures, bilateral fractures, and fractures of differing ages, vertebral fractures or subluxation, digital injuries in nervous epiphyseal separation, and complex skull fractures as well. Fractures that occur frequently but have a low specificity are mid-clavicular fractures of the parietal bone, single diaphyseal fractures with exception of spiral fractures, and green stick fractures. So once you find all these injuries, you need to date the fractures. Doc, this one, maybe, I don't know if you could explain this one. I don't think I can explain it very well for dating of fractures.
I think this is very similar to what Sada had said, how in the first 5 days you might not see anything. Sometimes you might see some soft tissue swelling, But after 10 days is when you start seeing some periosteal reaction, and where there's a fracture, you might see, because now there's colors, loss of the fracture line delineation and things like that. So I think it's where they use it now for dating to see whether it is early, peak, or late. But the main thing is to be able to pick up the fracture. And then to say if these fractures are of the same age or of different ages. Because if you get fractures of different ages, then you know this is something that has been ongoing. Yeah?
Mm.
So you can see some, you can see there's some soft tissue swelling, and another place you're seeing just periosteal reaction, another place you're seeing there's colors and that sort of thing. So fractures at different ages.
Okay. Right.
Mm.
Thank
And I guess for this, the dating, and I think it's like when you're using that skeletal age,
mm.
is like if they really wanted to know when do you think this fracture actually happened, then this is where now this table will come in useful, right? If you had one fracture, then you can look at it and say, where do you think it falls under? Then you can try and place it. Yeah.
Right. Thank you. So we can also have abdominal injuries, and this secondary to deceleration after a child is thrown. CT is a in investigation of choice. In the thoracic, the most common that you'll see is or something that you might see is diaphragmatic rupture, or also the rib fractures that are present also. You will see them on CT if you do it. You will see them. And then for the solid organ, the liver is injured more frequently than the spleen or kidney. If it's in accidental trauma, it is the other way around, that you'll have spleen, kidney, then liver. For bladder, if you see a bladder rupture in the absence of a pelvic fracture, it's most likely due to a direct blow against a full bladder. If the injuries to the urethra, those are you'll see following sexual abuse as well. Those ones will be seen. The pancreas, you'd see injury to the pancreas. This is due to a direct midline blow. This would occur at the junction between the body and the tail, and it's a common cause of childhood acute uh, pancreatitis. And then adrenal injuries can be isolated or in association with other visceral in injuries as well. Those would be on the right, and clinic and silent as well. For the GI, you'd have the rare. You they're not. It's not common for you to find GI injuries or bowel injuries in the duodenum. In the second and third part, are the most commonly injured areas. This is following direct compression against the vertebral column. You can have intramural hematomas of the duodenum and jejunum. The most frequent. This is the most frequent uh, bile trauma finding. And then hematoma can also act as a lead point for the subsection here. And then bowel rupture and perforation, commoner in the second and third parts of the duodenum and the ileocecal junction. Colonic injuries are rare, and then you have mesenteric injuries, which are severe injuries resulting from SMA avulsion. It was the most common. So the most common ones you'd see the pancreatic, and also if the patient has full bleed, would have the bladder injury. So we'll go through some of the skeletal cases that will have mostly the skeletal and head injury as well. That is seen. So for the first one, maybe I can go to this first to describe how the lesion may occur in shaken baby syndrome. You have the adult holding the child around the chest very tightly, and this might cause ruptures of the rib that is seen. And the violent shaking can cause subdural hematomas and contusions as well, because now the brain is being rocked back and forth within the cranial vault. And then you have injuries around the joints, mostly tibia, which would occur. That is due to because the baby cannot protect the limb, so you'll have mostly the corner or bucket handle fractures, as in when they're being shaken, they can't stiffen. They don't usually stiffen their limbs, just like a doll. So you have those injuries occurring. So you have a corner or a bucket handle fracture. So here you have a tangential view that results in the corner fracture, which is now you see on this side. This is the more severe forms of the corner and the bucket handle, and these are the less severe forms of the corner and the bucket handle pattern. And it's called a bucket handle because you can see now there's complete disruption of the epiphysis and metaphysis here. So it appears like a bucket handle there. So we'll go through the corner fracture. The person who first described this noticed that there were mostly more of these corner fractures that were associated with subdural hematomas, and now they make the connection between the two. They're often bilateral, and in the distal tibia, there's in the distal tibia, they're seen mostly in the medial side. This occurs when a small piece is avulsed from shearing force of the fragile growth plate, and is seen typically at the corner. So it's a corner fracture because of the avulsion and repetitive movement. Most common in the tibia, distal femoral, the distal femoral, the proximal humeri, as we said, they are usually bilateral. And then you have the bucket handle fractures, which are seen as the same around the same area as the corner fractures. These are avulsed bone fragments, and they're large, and they're seen in face as a disc or bucket handle. So these are metaphyseal fractures as a disc or a bucket handle fracture. So when you see this, you have higher suspicion that there's abuse there. So we go through cases now. A 7-month-old abused girl in whom carer admitted to physical abuse. Here you have a right humerus showing an oblique diaphyseal fracture, and then in 4 B, it shows transverse fracture. And if you can see, mostly seen in the mid radius and ulna. And then in image C, this is of the left arm, shows a transverse fracture of the radius and buccal fracture of the ulna. That's the same. And then on the chest, as there's a chest radiograph, you see more anterior. This was at a curving here, anterior rib fractures, which are now shown here. So this is the child abuse because you have multiple fractures.
Yeah, yes, because you have multiple fractures. Now, in terms of specificity, or once you can increase your confidence that this is an accidental injury, would it be anterior or posterior rib fracture?
Posterior rib fracture.
It's posterior rib fractures, yeah. That is true, and also fractures of different ages. Then the other thing would be like this diaphyseal fracture in a child who is not walking. Again, that would be high index of suspicion, and the corner fractures. Huh?
Yes.
Yeah. I think we talked about the others, the scapula, especially the acromion, the lateral clavicle. Yeah.
So again, this is a 2-month-old who presented with convulsion. The skeletal blaze shows now the distal. I forgot to say my disorder. I forgot what severe stands for. I checked, but it slipped my mind. Let me press one down.
Okay, she has connectivity issues, so let's give her some time to join in.
Different.
Yes, Sharon?
In the meantime, as she connects, just out of curiosity, how often do you see these cases, like on a monthly basis?
Oh, not that often, but it might also depend on how often you're downstairs reporting on these images, right? Yeah. So if I look back, I can think I've seen maybe two where you strongly suspect. Yeah. Mm.
Hello? Hello?
Hello. Yes, we can hear you.
Oh, sorry, I didn't know that I dropped off the call.
Right. Yeah, this is where you are. Okay.
Yes. So a 2-month-old who presented with convulsion, and you have the distal corner metaphyseal lesion, a classical, sorry, metaphyseal lesion that is senior to the corner fracture. And axial CT, there was absence of gray-white matter differentiation that was seen, which was consistent with severe hypoxia and a small subdural hematoma, although not properly seeing the subdural hematoma here.
No, you don't quite see that midline shift, but this
Yeah,
diffuse
around.
hypodensity and loss of gray white matter is quite alarming. Yeah?
Yes.
And this is the kind of brain, if you did an MRI, you may pick up much more. Because remember, in that, when the child is shaken, you can also get quite what might look like deep axonal, diffuse axonal injuries. Yeah.
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 All right. So again, so CT head was a patient who was admitted with a history of apnea at home. You can see there's a subdural on the left here around this area. Left occipital cortex, the face that was there, that was due to hypoxic changes.
The left, what about
Yeah.
on the right side?
On the right
It
as
is on
well.
the right, and even better see because it is going interhemispheric.
Interhemispheric. Yeah,
Yes,
yeah.
only that extends interhemispheric.
Then you know
Yes.
that's the subdural.
Yes.
Yeah.
And then here you have multiple rib fractures at different stages of healing. You have some anteriorly and others posteriorly as well. This is looks like a very fresh one, and others the bilateral.
Yes, and there's some quite close in the posterior rib,
Yes.
close to the vertebra. There are multiple.
Or close to that's
Yeah, even on the left side.
yeah. Oh
Mm.
yeah, yeah. Wow. So that's a case of an accidental injury, and also a diaphyseal fracture, as we said, for child maybe who is not for child who's not walking. And here you can see also the corner fractures that are present in the both the tibia and the fibula. And then I think this should be my last image. 4-month-old who was somnolent, presenting with the right periorbital hematoma. So you have CT and MRI, and they're seeing subdural hematomas with a hyper. This is hyperdense new collection that is in there. So these are older ones, and you have a new bleed. So this is a child who has been undergoing, who has had a history of
So
checking.
acute on chronic hematomas, isn't it?
Yeah, acute on chronic hematomas. Yeah, so which is just the same thing that we're seeing on the tooth, the flare and the tumor. Yeah. So that's the end of my presentation. Yes, and those are my references.
Okay, so thank you. And thank you for going through the appropriateness criteria. I mean, that was quite. And this is essentially it for
Yes.
pediatrics. Okay, right. So we covered everything else, interception, all that we've covered. Huh?
Yes, I did.
This was all covered.
Yeah.
Okay, fine. So what's left now?
From pediatrics, I don't think there's anything that's left. Yeah.
All right. Okay. Right. Sometimes
Where
we're in
in
centers
centers
where
where
they
they
have
have
nuclear
nuclear
medicine.
medicine,
instead of doing the skeletal survey, sometimes they can actually just do technetium 99 metastable that is labeled onto biphosphonates, and that you can, it actually has less radiation if you just do just the one scan, and then you can do a scan and see the entire body. Then you can see where the fractures are, right? Instead of doing all the different APs. In a child who you suspect might have a MAI. Yeah. So any questions? So just before we are having a long discussion with Dr. Mamo, and she's been wondering where you guys are. So I hope tomorrow you're all expected to be downstairs, isn't it, in the morning? Because it's your third years. I think Professor Omar is meeting with the third years tomorrow morning.
Yes, Doc.
Yes, so please ensure that you're downstairs.